Dan, and I want to thank Jonathan and the organizers for inviting me to give this talk. I wanted to give you a brief overview of the rapidly evolving field of DNA repair abnormalities and the consequences of that in prostate cancer. So the story arguably started several years ago when a group of us, a STAM to Cancer PCF group of investigators got together and what we wanted to do was interrogate the genomic landscape of patients with advanced prostate cancer. This was a difficult but challenging effort because we did biopsies in patients with advanced disease to determine their genomic landscape. And these are the results of the first 150 patients, and all of these dark boxes represent some sort of genomic abnormality. And as anticipated in patients with metastatic castration-resistant prostate cancer, there were frequent androgen receptor abnormalities, p53 abnormalities, p10 loss, as well as ETS fusions. What was interesting to us and observed really for the first time was a high frequency of DNA repair abnormalities, most notably BRCA2 abnormalities seen in these patients with metastatic castration-resistant prostate cancer, also abnormalities in ATM, BRCA1, as well as a low frequency of the mismatch repair genes. Wasim Abida from MSK then looked at our data set of over 1,000 patients, and what was unique about this data set is that it included patients with early prostate cancer, untreated metastatic non-castrate resistant prostate cancer, as well as metastatic castration-resistant prostate cancer. And it showed very similar findings. There's a low frequency of these DNA repair abnormalities in early prostate cancer. They increase in men with metastatic non-castration-resistant prostate cancer, and they're most abundant in men with metastatic castration-resistant prostate cancer. Once again, BRCA2 being the most common abnormality. Now, it turns out that a lot of this story, not all of it, but a lot of the story is in the germline. And this was first elucidated by a group of us led by Colin Pritchard, in which the germline was interrogated for DNA repair abnormalities in men with metastatic castration-resistant prostate cancer. And the frequency of these abnormalities in metastatic castration-resistant prostate cancer were compared to men with primary prostate cancer and to normal healthy men. And the important finding here was an incredible enrichment, 26-fold, in BRCA2 germline abnormalities in men with metastatic prostate cancer compared to normals or primaries, suggesting that BRCA2 and perhaps some of the other DNA repair genes were drivers toward aggressive disease. Now, we have had PARP inhibitors for a number of years. We've had platinum for many years. And we do know that in other diseases, such as ovarian cancer, DNA repair abnormal tumors are sensitive to these agents. And Johan de Bono's group were the first to study this in the context of prostate cancer. And this was published a couple of years ago, a study of very few patients, actually 50 patients, where he genotyped the patients for a set of DNA repair abnormalities and treated the patients with the PARP inhibitor olaparib. And to make a long story short, those individuals who had a DNA repair abnormality were much more likely to respond to olaparib than those who did not. In fact, the abnormalities were predictive of a response in 94% of patients. And this led to the breakthrough designation of olaparib for those individuals with BRCA1, BRCA2, or ATM abnormalities in prostate cancer. So a lot of us now are genotyping patients, and when we find these abnormalities, we're trying to prescribe olaparib for these patients. What about platinum in prostate cancer? This is a study that we did years ago in prostate cancer. These are men with metastatic castration-resistant prostate cancer who were treated with docetaxel chemotherapy, which at that time was standard of care, and they either had failed or were stable on docetaxel, and carboplatin was added to their regimen. And what we did was we went back and genotyped the germline of these individuals for BRCA2 abnormalities, and it turned out in this cohort of 141 men treated with carboplatin for metastatic castration-resistant prostate cancer, there was a much higher frequency of responses, and for that matter, profound responses to carboplatin than in the men, which is shown in red, than in the men who did not have a germline BRCA mutation. Now, we did not study the tumor itself. This is all germline abnormalities, so it's not the complete story, but it does indicate that, and not surprisingly, BRCA2 abnormalities sensitize tumors to platinum-based chemotherapy, which we see in other tumors as well. Now, a very interesting story that many of you know is that mismatch repair deficiency, or Lynch syndrome, is seen in a variety of tumors, and this hypermutated phenotype sensitizes tumor to PD-1 inhibition. In fact, about 50% of patients, as shown in this paper that was led by Luis Diaz, who is our head of division of solid tumor oncology, 50% of patients with mismatch repair deficiency responded to PD-1 inhibition, and a subset of those patients had durable, long-term responses. And I just want to bring to your attention, as I said before, somewhere between 2 and 5% of patients with prostate cancer have Lynch syndrome. And this is an important thing to find because potentially somebody who's been heavily pretreated could be treated with a PD-1 inhibitor and have a durable response to that agent. This is a little bit of biology. We became interested in what's driving this phenotype of aggressiveness in BRCA2 loss. And it turns out that when you look at databases, the common abnormality of BRCA2 is deletion rather than mutation. It's much more common to be deleted in early prostate cancer, advanced prostate cancer, than mutated as opposed to other tumors. So we just did the simple experiment of knocking out BRCA2 using CRISPR technology in a LNCaP cell line. This just shows that the BRCA2 has been knocked down with by CRISPRing out the BRCA2. And we studied the biology of these BRCA2 lost LNCaP cells, and they showed increased invasiveness in Matrigel. They showed relative hormone insensitivity when exposed to enzalutamide or when they were grown in charcoal strip serum, having no androgen in it. So they have a castration-resistant type phenotype, and they show increased genomic instability, which suggests also a more aggressive phenotype. I'm throwing in here RB, BRCA2. This is genomic instability. This is the BRCA2 RB combination. Now, BRCA2 and RB are very closely located on the chromosome, and it's frequent that both of these are lost when the deletion takes place. So what about clinically? How do we translate those findings into humans? There is this study that just came out. It's a retrospective study of men who were treated with primary androgen deprivation therapy and looking at the duration of response to initial androgen deprivation therapy with or without a germline, in this case, BRCA2 abnormality. And patients who had a germline BRCA2 abnormality, the duration of response to primary androgen deprivation therapy was truncated. The difference between having a BRCA2 loss versus a wild-type BRCA2 was 11 months versus 19 months, suggesting, as we showed in vitro, that there's a castration-resistant phenotype associated with BRCA2 loss. And then there's this very interesting study that was presented at ASCO, yet to be published, which was a randomized phase 2 study comparing abiraterone to enzalutamide. That was presented by Kim Chi from Vancouver. And the primary endpoint in this study, they took patients with metastatic castration-resistant prostate cancer who had been, and then randomized them to either abiraterone or enzalutamide. And the primary endpoint in the study was time to first progression. I'm not going to show you a lot of data that was shown at ASCO, but I'll tell you that enzalutamide tended to be a little bit better in terms of generating responses. And there was a slight hint in the fact that enzalutamide might have a slightly prolonged time to progression, but it was not statistically significant. The hazard ratio 0.82. Interesting, but the conclusion here is that there really is no major difference between the two with regard to response and response duration. What was most compelling was that they studied in circulating free DNA whether DNA repair abnormalities predicted response and response duration to these agents. And collectively, when you have either a BRCA2 or an ATM truncating mutation, you had a very low likelihood of responding to either enzalutamide or abiraterone. Comparison of those with abnormalities versus not, 1.8 months versus 8 months, multivariate analysis, a very high hazard ratio. This is all in keeping with, this is a bad phenotype in prostate cancer. And this just shows the time to progression for those in whom no circulating free DNA was detected, and that just speaks to the volume of tumor, presumably, in patients. This is the time to progression curve for those who had wild type BRCA2 or ATM, and these are the patients who had loss of BRCA2 or ATM. So that predicted a very poor clinical course. So here's my summary. DNA repair abnormalities are common in men with metastatic castration-resistant prostate cancer. This has now been shown since the original report in several data sets. BRCA2 germline and somatic abnormalities are the most common and frequently homozygous and heterozygous deletions occur. Not all of the mutations that we see are clinically significant. We're just beginning to sort out which are variants of unknown significance and those that are actually biologically important. We think, don't actually know, but there's a lot of accumulating data that's associated with an aggressive phenotype, in particular resistance to ADT therapy. The in vitro studies that I showed you that knocked out BRCA2 and LNCAP cells induce an aggressive phenotype, including castration resistance. And clinically, BRCA2 mutations are associated with PARP and platinum sensitivity. So here are the questions that remain. What are the implications for screening? Should all men with metastatic castration-resistant prostate cancer be screened for germline abnormalities in these DNA repair genes? Moreover, should we be looking for Lynch syndrome for those 2% of patients that might be sensitive to PD-1 inhibition? My answer to that, although it isn't necessarily widely accepted, is yes. And in fact, we do that here as a routine. We are looking at the tumors and the germline in patients routinely. Should low-risk patients, and I should also mention, what about high-risk localized patients? Should they be looked at as well, where the frequency is lower, but still it occurs? What about low-risk patients, patients with Gleason 3+3 or 3+4 tumors? What if we were to find a DNA repair abnormality in these patients? Would you look at them differently with regard to active surveillance? And I'd love to hear what some of the urologists say to that. Should those individuals with localized disease be treated differently if they have a DNA repair abnormality? Should platinum or PARP inhibitors be part of their regimen? off of a clinical trial, I think at this point, I would say it remains a question mark. BRCA2 loss is associated with increased genomic instability, which is interesting because it might sensitize these tumors to immunotherapy, perhaps in combination with a PARP inhibitor, and there is some preliminary data that that might be the case. Thank you very much.